family, hello friends. This is Dr. T and welcome to Clinical Medicine. So guys, people have actually reminded me guys that I haven't finished our topic on NSAIDs. NSAIDs. So we've done part 1 of this video where we are trying to understand why are NSAIDs horrible drugs for the diabetic and the hypertensive patient, more especially when the patient is already having a renal impairment or is having some kind of nephropathy, whether it's diabetic nephropathy or hypertensive nephropathy. That's what we are trying to answer here. So we've done part 2. So please guys, watch the first part before you can watch this one, right? So that we can be on the same page. So this is where we ended on the first video. On the first video, we're saying normally you have this structure called, or this lipid called arachidonic acid. Arachidonic acid, and arachidonic acid needs to be converted to prostaglandins, prostacyclins, thromboxane. So all of these, if you take a look at them nicely or closely, they are all inflammatory mediators. So when we are injured, when the cells have been injured, for us to heal, we need inflammation. Inflammation is very crucial for healing. So once we are injured, we need to convert our arachidonic acid to these guys so that they can initiate the inflammation. How do they do that? One of the things that prostaglandin does is to, if this is a blood vessel and this is an area where cells have been injured, be it burns, be it trauma, be it whatever, so prostaglandins will come in and vasodilate this, make it bigger. And the reason why vasodilation has got to happen is because, yes, there will be a lot of things that's going to happen there, but the reason why there is vasodilation is because you want white blood cells to flock to that area. You want oxygen because there's going to be a lot of mitosis that is happening. And mitosis is an active process that requires energy, and there will be a lot of CO2 that needs to be taken away to the lungs. There will be a lot of so you will need nutrients, right? So there will be a lot of things that are needed to that area. Now, one of the things that inflammatory mediators do is to make these cells to be leaky, the endothelial cells to be leaky, so that these guys can actually make their way into the surrounding damaged cells, right? When that happens, when this has happened because of these guys, you're gonna get redness there called erythema. So the redness is because of the vasodilation that occurs here. That's why you get redness. And also there will be swelling. The reason why there is swelling is because you've got leaky endothelial cells. Now, not only white blood cells, they start to seep out of those small openings there. Even fluid starts to get there as well. Even some blood also gets there. Now this becomes swollen, and when it swells up, it becomes painful. And because it's so painful, you actually lose function of that. Especially if it's a limb, you don't want to touch it, you don't want to use it, so loss of function, right? And because of the blood that is getting to that area, a lot of blood that is flowing to that area, you will get increased pain. So there will be warmth. So that place is going to be warm. So basically, if you look at all of these are the signs of inflammation because of these guys. But these guys are able to initiate all this cascade, all this process. They are able to get it going simply because arachidonic was able to be converted to these inflammatory mediators. So the point I'm trying to make here is to explain why we need inflammation, right? It's because we want healing to occur. But inflammation does not come alone. It comes with problems. It comes with pain. It comes with swelling. It comes with loss of function. If it's a finger, you can't use it. If it's a leg, you can't use it. It's painful and all of that. Now, just to go back, arachidonic acid alone cannot do all this. It has to be converted to this. And also, I mean, the way the body has been sort of like organized is so organized. Because imagine if you had prostacyclins and prostaglandins and thromboxanes just floating around in the body, you will actually get conditions. Imagine having inflammation. You've got inflammatory mediators that are always flowing in the blood, floating and flowing in the blood. They will just initiate the cascades even though it's not necessary. So that's why everything needs to be controlled. So as long as you've got this guy, you can't get to here. So you need to move from here to here. Now, to move from here to here, you need special enzymes, cyclooxygenase enzymes. Commonly known as, or commonly referred to as COX enzymes, right? So these COX enzymes, cyclooxygenase, they are able to convert arachidonic acid to these inflammatory mediators that we spoke about: prostaglandin, prostacyclin, thromboxane. Now this enzyme has got two isoforms. There is COX-1 and then there is COX-2. Now these enzymes are crucial when it comes to converting arachidonic acid into those inflammatory mediators. Now, people back in the day, they were like, okay, we love inflammation because it helps us to actually get better and heal. But the pain that it comes with, the swelling that it comes with, and this loss of function are not nice things to actually have to endure just because you want to get healed. So people decided that we can actually come up with drugs that can block this enzyme from converting arachidonic acid into these inflammatory mediators. So that's when the story of NSAIDs came. Non-steroidal anti-inflammatories. So there are NSAIDs that are able to block only COX-1. There are those that can only block COX-2. Those are called selective COX inhibitors. So selective COX inhibitors can either block COX-2 or COX-1. The drugs that can block both COX-2 and COX-1, they're called non-selective. Now, a lot of the drugs that we have, they are non-selective. I'm talking about your brufen, your diclofenac, your naproxen, your Indosid or indomethacin. The list goes on. So most of the drugs that we have, I mean, it makes sense that you give a patient a non-selective, because if you give a selective COX inhibitor, you will allow the other enzyme to actually continue converting arachidonic acid into those, and you are gonna get all of this. So now, there is no way you can give a patient NSAIDs to block, even if you give a non-selective COX inhibitor, there is no way you can block all of those enzymes in the body. You will block some that will just minimize the swelling, minimize the pain, and minimize the loss of function, but you cannot wipe out all of those or block all of those COX enzymes that you have. That's why even if you take NSAIDs, you will still feel a bit of pain, you will still feel a bit of swelling, you will still feel a bit of loss of function, right? But it will be bearable. That's the whole point. It will be bearable. If you were to try and block all the COX enzymes in a patient's body, you actually have to give high doses of NSAIDs. And remember, high doses, the more dose you give a patient, the higher the chances of them actually getting side effects. So the safe drugs, the safe doses have been calculated for us to use because they are within the safe range and all of that. So this is the whole point about NSAIDs, why we use them and all of that. Now, before we can move on to the next part of this discussion, is to understand that prostaglandins are good vasodilators. That's one thing that I want you guys to keep as we move on to the second part. So let's meet on part 3, guys.